Medical news from The Lancet. Oncology. Systemic therapy, gastrectomy, cytoreductive surgery, and hyperthermic intraperitoneal chemotherapy versus systemic therapy alone for gastric cancer with limited peritoneal metastases. Periscope 2 final results of a multicenter, randomized, controlled, Phase 3 trial after an unplanned commissioned interim analysis. Gastrectomy combined with cytoreductive surgery and hyperthermic intraperitoneal chemotherapy, HI HIPEC, does not extend survival for patients with gastric adenocarcinoma and limited peritoneal spread when compared with continued systemic therapy alone, and it adds a substantial burden of serious toxicity. This finding is crucial because HI HIPEC has been widely adopted in many centers despite a lack of high-quality comparative data, and clinicians now have robust Phase 3 evidence to guide treatment selection for this high-risk group. Gastric cancer remains a leading cause of cancer death worldwide, and peritoneal metastasis is the most common pattern of recurrence, conferring a median overall survival of less than a year with standard chemotherapy. Small volume peritoneal disease, peritoneal cancer index 7, or positive peritoneal cytology after initial systemic therapy has been considered potentially amenable to aggressive loco-regional approaches, yet prior studies have been limited to single-arm series or retrospective comparisons, leaving uncertainty about the true benefit of adding surgery and HIPEC to systemic treatment. The Periscope 2 trial was therefore designed to fill this evidence gap by directly testing whether an aggressive multimodal strategy could improve outcomes over the current standard of continued chemotherapy. The trial was an open-label, multicenter, randomized controlled Phase 3 study conducted in 8 tertiary referral hospitals across Europe. Adults with resectable CT3, CT4 gastric adenocarcinoma and limited peritoneal metastases, PCI7, or positive peritoneal cytology, who had not progressed after at least 3 cycles of systemic therapy, were eligible. Between November 2017 and August 2024, 102 patients were enrolled and randomized 1:1 to either continue systemic therapy, standard arm, or undergo gastrectomy plus cytoreductive surgery with HIPEC using oxaliplatin, 460 mg per square meter, followed by systemic therapy, experimental arm. Baseline characteristics were balanced, with a median age of 60 years and a predominance of white participants, 85%. Median follow-up was 67 months, providing mature survival data. The primary endpoint, median overall survival, was 16.6 months, 95% CI 14.1 to 1.9, in the standard therapy group versus 15.7 months, 95% CI 11.4 to 5.5, in the experimental group, yielding a hazard ratio of 1.10, 95% CI 0.691.74, p equals 0.70. Thus, the addition of surgery and HIPEC did not confer a statistically or clinically meaningful survival advantage. Toxicity was markedly higher in the experimental arm. Grade 3 or higher adverse events occurred in 42% of patients versus 20% in the control arm, and serious adverse events were reported in 44% versus 6% respectively. Treatment-related mortality within 100 days was confined to the experimental group, with 3 deaths attributed to acute respiratory distress syndrome, anastomotic leakage, and postoperative bleeding. No subgroup analysis demonstrated a survival signal in any particular cohort, and secondary outcomes such as progression-free survival mirrored the overall survival findings. These results suggest that, for gastric cancer patients with limited peritoneal involvement who have already responded to systemic therapy, proceeding directly to gastrectomy with cytoreductive surgery and HIPEC should not be considered a standard of care. The data reinforce current guideline recommendations that prioritize systemic chemotherapy as the backbone of treatment and caution against routine use of aggressive loco-regional surgery outside of clinical trials. Clinicians should instead focus on optimizing systemic regimens, supportive care, and enrollment in trials exploring novel targeted or immunotherapeutic approaches for peritoneal disease. Interpretation of the trial must acknowledge several limitations. The open-label design could have introduced performance bias, and the relatively small sample size, though powered for the primary endpoint, may have limited detection of modest subgroup benefits. Additionally, the study excluded patients with more extensive peritoneal disease, so the findings cannot be extrapolated to those with higher PCI scores. Nonetheless, the rigorous randomized design and long follow-up provide compelling evidence that HI HIPEC does not improve survival in this selected population and carries a higher risk of serious complications. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.